Hello, I'm Locke Meredith. I'd like to invite you to join me on the next Legal Lines, where my guest is Dr. Henry Barham. Dr. Barham is a rhinologist. He just got published in JAMA, the Journal of American Medical Association. Big deal. Why? He developed a test that may help determine the severity of your symptoms if you get COVID. The question is, are you a super taster, middle taster, or no taster? You need to know. So join us on the next Legal Lines with Dr. Henry Barham. I'm lawyer Locke Meredith. If you're battling an insurance company because of a wreck not your fault and they're not calling you back or being fair, whether you hire us at all, give us a call, 272-5555, or email Locke Meredith, Sean Fagan and Associates. You have nothing to lose.
Hi, I'm Sean Fagan of Locke Meredith, Sean Fagan and Associates. When insurance companies have been unfair, we've never been afraid to go to trial. Fighting hard to protect your rights, we never settle a case out of convenience. We only settle when it's right for you. Whether you hire us at all, give us a call.
Hi, I'm Mitchell Meredith. Injuries happen when you least expect them to, making your life more complicated. At Locke Meredith, Sean Fagan and Associates, we know this and we strive to help each of our clients during these times. Whether you hire us at all, give us a call at 272-5555.
I'm lawyer Collins Locke Meredith. Trust is important when hiring an injury law firm. At Locke Meredith, Sean Fagan Associates, thousands have trusted us and gotten the results they deserved. Visit us at LockeMeredith.com. Whether you hire us at all, give us a call, 272-5555.
Hello, welcome to Legal Lines. I'm Locke Meredith, and I'm very pleased to have on the show, this is a very special show, Dr. Henry Barham. He is an ENT here in Baton Rouge, and he has developed some very special, unique products. Henry, it's fantastic to see you.
Thanks so much for having me.
I'm very excited about this show because it means a lot to everybody, honestly, and could potentially have real positive effects for the world and for the longevity of folks. So, first of all, that's a big open, but tell folks why they want to listen to you. Give them your education, background, that kind of stuff.
Yeah, first, thanks for having me. So,
of course.
I'm Henry Barham. I grew up in Louisiana, so I grew up in the northeast part of the state in Oak Ridge, a little farm in town. And
a lot of red soil.
That's right. So came, well, it's in the Mississippi Delta, so we had different, but came to LSU for undergraduate and then LSU Med School in Shreveport, and then I went to residency or completed a 5-year otolaryngology or ENT, as you said, residency in Colorado at the University of Colorado. And then I did a year fellowship in rhinology, which is you treat diseases of the nose, sinus, and skull base. And so I did that fellowship in Sydney, Australia. And then came back to Baton Rouge, married a girl from outside of Baton Rouge. You got it. So we moved back here and came back and was with LSU initially at Mary Bird Perkins, and then in 2016 we started, my partner and I, Christian Hall, and I started a practice, Sinus and Nasal Specialist of Louisiana, where we we have a dedicated practice to rhinology, so we just treat diseases of the nose, sinus, and skull base.
And in the context of all of that education, you've done a considerable amount of research and written all kinds of papers and chapters of books, and tell folks about the research and your publications.
I've been incredibly fortunate in training and career. I've had incredible mentors. From my parents to my wife to mentors in medicine, some of which are phenomenal researchers in addition to great teachers. And part of the reason I went into rhinology is it's an incredibly new and rapidly developing field. And so it's a subset of ear, nose, and throat that really uses a lot of minimally invasive like endoscopy. And so most of our surgeries use endoscopy. So we're using tiny cameras up the nose or up the nostrils to do what used to be incredibly large incision surgery, now is very minimally invasive, but with much better results because it's much better visualization. And the instruments have sort of kept up with the visualization. And so it's a really cool field that is a lot of fun, but also because of the evolution of this field, the research is, I am passionate about research because I think it's just such a fun and interesting time to be able to push our field forward since I was able to catch it early in the development of this field, so rhinology, and so there's a lot that we don't know. And so that's kind of exciting because I get to spend
a new frontier, huh?
Yeah, you get to spend a career to find new things and, you know, figure out new ways to treat diseases, and that's incredibly rewarding.
Well, and you have. I mean, let's kind of spill the secret here, not secret anymore, and that is that you have developed a product that you've used, not a product, a test that helps folks who have COVID potentially determine in advance even the severity of their symptoms.
Yeah, and I mean, the way you described it is great. So in advance is important because, so sort of back up a little bit to your point, we basically have looked at a family or a group of receptors that we had studied previously to sinusitis, to inflammatory diseases that appear.
Define receptors for folks.
Yeah, so basically, okay. So part of your innate immunity, so it really gets into the difference of types of immunity. So you have innate immunity.
Just make it simple.
You got it. So innate immunity and humoral immunity. The difference there is innate immunity is something you're born with. That is your initial barrier of defense, sort of like your
armor, so to speak.
Prevent things from coming in. And you don't really change that much. Okay, so then you have humoral immunity. Well, that's what most people recognize as immunity, where that's systemic. That's in your bloodstream. Those are antibodies and things like that. So people hear about the vaccine. That is stimulating your adaptive or your humoral immunity. What we're looking at with these receptors is really that barrier, so that innate immunity. And so there's this family of receptors that was previously studied in rats where they'll use it to sort of sample things in their environment to warn them, don't eat it or don't ingest it because it's potentially harmful. It's a pathogen, okay? And so it will stimulate them to turn away from that. Yeah, and so
so it's a warning.
Yeah, and in addition to that warning sign, they actually do some cool stuff. And so they stimulate your body to have little hair cells to sort of sweep things along and increase mucus to sort of dilute things out. And then one of the things they produce is nitric oxide. And so nitric oxide has been shown previously to SARS-CoV-1 to help prevent maturation of the spike protein, or the spike protein that people have sort of learned about recently.
The little
or heard
thing
about,
sticking up off the round ball.
The picture of COVID that you see. It prevents that from maturing. Well, a virus needs a host to mature, to live. It can't really live on its own. And so if you prevent that virus from continuing to replicate, it's going to die off. And so that was kind of the thought of
the theory behind it all, and the medicine,
the
anatomy of it all. So you started doing tests on your patients and hospital personnel. First test was, I think, about 100 people? Explain that test to the folks.
Yeah, so basically what we did was I sort of knew a good bit about these receptors from my time in Colorado, where I'd spent time in the lab under, as I said earlier, great mentor, Vijay Ramakrishnan. And so basically I had sort of an idea of why this maybe could make sense. And so what we did was we just tested people that had COVID to this quote taste test, because it's not necessarily a true taste, but tested that to see if it held any weight, and that was kind of how the retrospective or the old study started.
And so your findings turned out to be what?
So it was pretty impressive. So we tested 100 people who all had COVID, and of the 100 people, we had 0 people with very high expression. We had 79.
When you say high expression,
so like when they
define that lay terms.
Yeah, so it's like when I say a taste test, they're going to put this strip of paper or a couple of strips of paper with a chemical on their tongue, and if you perceive it as intensely bitter, then that would mean or suggest that you have very high expression of these receptors, because that's that receptor activating. It's like the rat response when they perceive something, they turn away from it. It's an unpleasant response. Okay, so we didn't have anyone in that group, in the high-end group, that got COVID. We had 79 in the middle group who had some level of expression, and 0 out of those required hospitalization. We had 21 out of 100 who didn't perceive the receptor or didn't perceive the taste, and all 21 required hospitalization.
And some were on respirators. All right, we'll continue this on the next segment.
Yep.
This is Locke Meredith, Legal Lines. My very special guest, Dr. Henry Barham. We'll be right back.
Hi, I'm Sean Fagan of Locke Meredith, Sean Fagan and Associates. Open the phone book or look online. There are plenty of lawyers to choose from. And if you ask any of them, they'll agree that the vast majority of claims settle without ever having gone to trial. And I'll tell you, any lawyer can settle a claim. It's not hard to settle a claim, but it takes hard work to get a client what he or she deserves. At Locke Meredith, Sean Fagan and Associates, we have a proven record of working hard for our clients. Whether you hire us at all, give us a call.
Welcome back to Legal Lines. I'm Locke Meredith, and again, pleased to have on the show for the first time Dr. Henry Barham. He is a ENT and a rhinologist.
You got it.
Let's dive back in because this is so fascinating. Bottom line is you have developed a taste test that helps possibly determine your immune response to COVID or anything else. Is that right?
You got it. And so kind of back where we were, so the initial retrospective study that we did.
Retrospective meaning?
Meaning back in time. So like you...
Past...
Yes, so the people have already come through the illness, basically. So what we did was, I had this idea, is like, I wonder if this receptor matters to COVID, because I know one of the byproducts of this receptor is nitric oxide. Well, previously shown in a great study to SARS-CoV-1 that nitric oxide on a local level, like on your surface, prevented the spike protein from maturing. And so I thought, well, I wonder, could this predict anything? And so basically what I did was I tested 100 people who had already had COVID, right? So that's why it's retrospective. They've already come through the disease.
And you know they all had it.
You got it. And so when I tested them, I tested 100 people, 0 of them had high expression of this receptor per the taste test. 79 had medium level of expression of the receptor, and 21 had no expression of the receptor.
Now, when you use the word expression, in lay terms, it didn't taste horribly bad, bitter.
Yeah, so basically, I'd give a taste test with several of these little litmus paper strips that are coated in certain chemicals, right? And it's actually 4 strips of paper in different chemicals, basically because it's a whole family of receptors, around 25 of them. And so based on how intensely you perceive them, that's actually a byproduct of the receptor. So when the receptor activates, it produces this response, and you perceive it as a taste, or in some people an unpleasant taste. Some people perceive it as sweet. Well, based on what you perceive and how intensely you perceive it will sort of show how well your receptors are working, okay? Well, if you actually look across a population, you inherit these receptors. Your genotype or your genetic makeup says that around 25% of people should have very high expression of these receptors. Around 50,
which we now call supertasters.
You got supertasters. You got it. 50% is the middle group, and they should basically got one good gene and one not so great gene, and they have sort of middle, level of expression.
Tasters.
and then non-tasters got 2 bad genes, and so they don't really express the receptor, and so they won't taste anything to certain chemicals. There are a couple of the strips that actually have chemicals that they will perceive, but that's actually how we validate the test, okay? Well, if the population should be around 25%, 50%, and 25%, that's why the results were kind of interesting, because we didn't have anybody who had COVID who was in the high expression group or the super taster group, as you said. We had 79 in the taster group, and we had 21 in the non-taster group. Well, all 21 of the non-tasters required hospitalization. They had a terrible course of disease to COVID. Of the 7,
non-taste is bad.
Yeah, in the initial study. Okay, so then we had 79, and the number should be around 50, so that was kind of higher than we thought, but 79 were in the middle group. Well, none of them required hospitalization. Okay, well, I thought, well, one, that data has to be flawed, and put some potentials there, okay? Maybe it's the loss of smell and taste. Everybody knows, like
right.
COVID, you lose your smell and taste, or like 60 to 80% of people lose their smell and taste. I thought, okay, well, that's why. Well, this is, it's throwing off this taste test. And so, but then, that's kind of didn't necessarily make sense perfectly, because smell is on a different cranial nerve than these receptors transmit through. And really taste is too. So taste is on a combination of a couple of cranial nerves that transmit into your brain.
Interesting.
Well, this perception is actually on a different receptor also. And so, that was kind of the thought of now this prospective study. So prospective meaning we basically took a group of people who had not had COVID, we tested them to this taste test to measure their receptors. We then followed them until they got COVID, and then we repeated the test on them to see, number one, did it change when they lost their smell and taste? And number two, was it predictive of outcome? And that's the paper that we just published in JAMA on Tuesday.
And JAMA stands for?
The Journal of American Medical Association.
It's a big deal to get published in JAMA.
It's a real honor, honestly. That was really kind that they did it, but it's encouraging that we're able to get this data out there, and so that's been a lot of fun.
So this second test was folks who didn't have COVID yet. You check their taste to see if they're super taster, no taster, or middle taster. They then get it. You know what their symptoms were like and how bad it was or how minimal it was, and then you test them again, their taste, to rule out one, that the loss of smell is not an issue, and then to determine the severity of symptoms based on their response to those those tasters and the three groups.
Yeah.
So how did that happen? Well, how did that fall out?
Yeah. So this is.
And this was 2,000 people, right?
Right. And so this was admittedly this is me totally nerding out, but was super exciting to basically, okay, you already have a retrospective study that you've just done, and you know the potential flaws. How do you design a new study to account for those flaws to disprove
it was smart
them?
to do before and
Well, that's
after.
part of the scientific method that I think is actually really kind of exciting. Is okay, you have an idea. Your whole point is to disprove it, right? You got to prove yourself wrong. Okay, so loss of smell, we accounted for that. Was it an alteration that they already had COVID? So basically what we did was we took this group of people, we tested them initially to COVID, basically with a PCR test to see if they currently had COVID. We also did an antibody test to prove that they didn't previously had COVID, meaning maybe when we catch their results on the first end, they're already altered. We wanted to prove that wasn't the case.
You want it before?
Yeah.
In advance.
Right, and then we followed them, and actually in a subgroup of them, we also did a genetic analysis, meaning we actually measured their genetic makeup to see how accurate our interpretation of this taste test was at actually predicting.
So you
what it should
eliminated
be.
possible reasons to make it not valid,
Right.
and then you collected as much data as you could.
You got it.
To deal with the symptoms, the information you received.
Right, so it was just under 2,000 subjects, and we followed them. And then basically 266, or around a little over 13% of them got COVID. Now, we have continued to follow this, and the data set is actually much larger now, on the magnitude of around 17,000. But what we just published was the first 2,000 subjects, or 1,930 some subjects, followed them, and we did it just for the first 3 months, and that was only 13% converted to COVID. And basically, the crazy results, they stood true. So basically, of those requiring hospitalization, 85% were non-tasters, 0% were super tasters. That left 15% in the middle group, but interestingly, the youngest person in that group requiring hospitalization was 69, and the average age was 74. And the reason that's important, these receptors wear off as you get older. And so you start to trend towards the non-taster group, even if you're in the middle group.
Wow, so the poor older folks like me are going down the
I
toilet.
wouldn't call you older yet.
No. So bottom line is, super taster, you're going to be okay in all likelihood. No taster, you're going to have a tough time. Hopefully we can deal with it with therapeutics. All right, we'll continue this on the next segment. Locke Meredith, Legal Lines, Dr. Henry Barham. We'll be right back.
Hi, I'm Mitchell Meredith. Injuries happen when you least expect them to, making your life more complicated. At Locke Meredith, Sean Fagan and Associates, we know this, and we strive to help each of our clients during these times. Whether you hire us at all, give us a call at 272-5555.
Welcome back to Legal Lines. I'm Locke Meredith. Again, very pleased to have on the show for the first time Dr. Henry Barham. We're talking about some pretty impressive stuff relating to COVID symptoms and possibly being able to predict it.
Yeah.
So quickly just summarize what you told me in that previous segment.
So in the paper that we just published in JAMA, so the results of the study basically appear to predict your duration and severity of symptoms if we knew what group someone or their level of expression was prior to them getting COVID. Meaning, if you just look at symptom duration, super tasters, those with high level of expression of these receptors, their average duration was 5 days. Middle group, so that's around 50% of the population, the taster group, their average duration was 13.5 days. The non-taster group, which should make up about 25% of the population, their average duration was 23.7 days. So really you have 5 days versus 2 weeks versus 3.5 weeks across the population, or our cohort that we studied. Hospitalization rate, 85% of those requiring hospitalization were in the non-taster group, 0% were in the super taster group, and basically the taster group, the 15% requiring hospitalization that were in that group, trended towards the older population, meaning these receptors wear off as you get older, just like hair color. So if your genetics say that you have brown hair, by the time you're 75, if it's gray, it doesn't mean that your genetic makeup has changed to gray hair. It's just your phenotypic expression, which is your outward showing of your genetic makeup, but based on diet, age, overall health status. It's the outward expression of it, and that tends to decline as you get older. And so the thought was, how do we help people? How do we get this out? And so I've been very fortunate to work with a company now called Phenomune, who has now developed this test that we use during these studies, basically the interpretation of how you measure someone's level of expression.
And you have one of those.
Yeah, so
strips,
I have some examples of the strips, but actually it's much nicer than this when it comes to, it's something that people can order at home, basically. They just order it online, it ships to them, they do the test at their house, they enter it on their computer or on their phone, and it automatically calculates it for them. It tells them what group they're in. There are also ways to potentially stimulate these receptors. And so they're doing a great job of really walking through this whole journey with these people, because what we're now seeing in this, as we continue to study this, is that it's not just COVID potentially. It looks like it's also
That's what's
potentially
amazing too.
So predictive maybe of, what we're studying now is to influenza, upper respiratory infections in general. Obviously, there have been great research studies previously and great researchers that have shown this predictability to bacterial infections and how they work to certain bacteria, and also inflammatory conditions. And so previously shown those who have low expression have a much higher incidence of chronic sinusitis, chronic inflammatory conditions, and asthma, diseases of the airway.
And that's due to their innate immune.
That's the thought there. And so that's
immunity.
Yeah, and so that's what we continue to study. And so as this continues on, what if there's another, novel virus? What if there are more mutations of coronavirus? This should stand true, because it's, this is something that we've had the whole time. And when people say like, well, it didn't make sense, this person didn't get that sick, and this person who's healthy and exercises, they got really sick, there had to be something genetic about it. There had to be some predisposition. And that's what this data would suggest.
So this helps you basically identify the folks who are the most susceptible to needing extensive treatment, hospitalization, maybe respiratory help. The other two groups, being the super taster and the minimum taster or middle taster, they're more likely than not going to have horrible symptoms.
And that's where, so
you can allocate resources.
That's where it has great potential. So as a researcher, I tend to be, especially in science, skeptical. So, a lot of things don't make sense. And when this came out, it was like that, this is really weird. What is this novel virus that is literally taking over our world? Not only medically, but financially, now politically, it has people scared, and rightfully so. It is a bad virus, yes.
Millions and millions of people.
Right, and so basically I didn't believe it was true, but what I do believe in is data, and I do believe in the scientific method. And so the data would certainly suggest that this is predictive. And so that is where...
This is predictive.
This test is
of
predictive.
Your symptoms.
Yes, and so there are certainly other things that weigh in. And so in our data set...
Comorbidities.
Certainly. Once people get sick, that's where that factors in.
What are they?
So diabetes, history of smoking, obesity, or being overweight, older age certainly does. Basically your lack of ability to mount an appropriate immune response. And so that
generalized health?
Yeah, that goes down as you get older. And so those factors weigh in once people got sick. And so what was so excited about this, and what was so exciting about what Phenomune has developed, is a way for people in their own home to be able to test and potentially identify their initial response. Now, sure, comorbidities weigh in because what we're looking at is your initial barrier, if you remember. Now, once you get it, that's where comorbidities weigh in because they're going to change how severely you act to it. But what if this has helped predict, what if this has helped, preventative in certain people? And so if we can find ways to stimulate these receptors, you're helping potentially prevent as severe of illness that they get in the first place. And so that's what's really exciting.
And then this has application generally just for an improved life, right?
That's one thing that I think that this company has done a great job of is like more than just this. How are ways that we can help people in the future improve their overall lifestyle, their overall health, and their quality of life ultimately as a result?
And this taste test kind of helps figure out where you are, right?
Yeah, well, it's a good baseline of a starting point, and then we go from there of sort of improving overall health.
So how do folks get this taste test? I mean, how
for
do you
this
spell
one,
the name of the company?
Yeah, so for this one specifically is Phenomun, so it's Phenomun, Phenomune.com, and so you go there, you literally just order it to your house.
Do the taste test.
You got it.
Now, you said you enter data.
And so
what is the data? I guess how severe the taste was?
So fortunately, it's more than just COVID. So this is not designed to be a predictor of COVID. It's an overall health and wellness. And so basically, on this specific part of that, they take this test, they enter on there what they perceive, what they taste, how strongly they taste it. It's got a scale on there and shows them
1 to 10 or something?
Yeah, 0 to 10. Walks them through it to each strip, gives them examples of how to do it, and then gets their score.
Immediately, right?
Yeah, it calculates it for them and shows them. And it actually has multiple tests in there, so it's not like it's just a one-off. So you can take it a week later and see if it's changed.
You turn out a notation and go, hell no, going again, baby.
I'm keep going, figure this out. And so that's been really exciting to work with them on that.
Now talk quickly about, in your practice, you've treated hundreds of people, if not thousands now, with COVID. How are you treating the folks when they show?
So personally, what we did, I wanted to stay in my lane. Okay, I wanted to stay in my lane and not overreach. And so I know about these receptors. And so what we did, and this is a study that we also just published on a treatment protocol, is if we knew what group or their level of expression, we treated with medications to stimulate their receptors if they had them on what level to try to help them have a less severe disease.
What medications are you using?
So dexamethasone or a steroid in general to help decrease the inflammatory response and decrease the loss of smell. Azithromycin, which is an antibiotic, helps to stimulate one of the receptors. And then there's other stimulants of these receptors that we've been using. Thank you so much.
Thank you very much. It's Locke Meredith Legal Lines, my very special guest, Dr. Henry Barham. Thanks for being with us.